Yes, I'm going to talk about our dosimetric experience with planning uses surface-guided planning. Same title. No disclosures. So as Helen and David talked about what is MapRT and what is clearance mapping, so I'm going to kind of walk through that fast. So I'll introduce what is MapRT, clearance mapping, talk a little bit about what are non-coplanar treatments, even though it's already mentioned in a couple of talks already, and then what we did with our MapRT evaluation, and then talk about conclusions. It's our hospital in Florida. We have 15 radiation oncology centers, 19 LINACs, 1 gamma knife, 3 HDRs. We do IORT and a slew of SGRT systems. So we do a wide variety of treatments, even SRS SBRTs on the gamma knife and LINAC, so plenty of option to try new things. So with traditional treatment planning, you're relying on your CT, MR images, and images are taken in your sim room with little correlation to actual treatment environment. Some treatment plans will require dry runs to ensure the patient and/or accessory is clear. So even if you're not doing non-coplanar arcs, you might have accessories, just like David showed in his slides, that might be in the way, and you kind of need to have a way to evaluate that. And if you fail a dry run, that will result in basically replanning, which would lead to some delays in treatment in some cases. So MapRT, as was mentioned before, it uses 2 lateral wide field cameras. They image the entire surface of the patient and their accessories, and you get a 3D model that can be used to calculate the clearance map for every couch and gantry angles. That treatment can be imported to, a treatment plan can be imported after calculation back into MapRT to verify that all the angles, couch and gantry that you picked will clear, and you basically do a virtual dry run and remove all doubts about treatment or translational collisions. So that's how it looks. That's not our CT room. Ours are being installed at the moment, so, but you've seen them in other slides. Again, this is the virtual space of the MapRT setup, and how you would, the other image here is what you would see with your post-plan collision test. With non-coplanar radiotherapy, you basically treat at non-zero couch angles. Your beam arrangement can help improve your tumor coverage, as David beautifully showed, and lower dose to your OAR. However, it introduces the risk of collisions, and you need clearance verification prior to delivery. If you do a quick literature search, you'll see there's plenty of papers out there that show the advantage of non-coplanar treatments for various treatment sites. This one's a more general, introducing the topic. This one talks about left-breasted, including the mammary nodes. This one's breast 2 and breast. I focus on breast because our clinic treats about 60% of the patients are breast, so that's our main focus. But you can find the same about lung, head and neck, SRS, obviously, and other things. So it's very helpful. So in our evaluation, David was kind enough to send us a slew of surfaces that they scanned in their site for us to kind of try to introduce non-coplanar approaches and see if that's going to benefit dosimetrically. And in our sites, we don't do many non-coplanar outside SRS and SBRT, so it was interesting for us to see if in traditional plans for maybe breast or brain or lung or other kind of body sites, it would be beneficial. So we started with the brain one, and David was kind enough to send us a really nice brain setup of the patient was in almost an 18 cm angle leaning up. So there's definitely a collision risk there. So that was really interesting to see how we can find the coplanar and non-coplanar plan and kind of compare them, and I did the majority of the planning myself because I wanted to be consistent between both and throughout. And I try to make sure I have the same iterations and spend about the same time on both plans such that I don't over-optimize one plan or the other to make it unfair. So with a two-field VMAT plan, just 2 arcs, and this is kind of like the constraints table that we use. With a few optimizations, that's kind of like where I stopped. And if I could reduce the hotspot a little bit, it would probably be clinically acceptable to treat at our center. So that was a good starting point. I tried to add a 3rd arc to see if it made a difference, try to get some of that hotspot down, and the lens dose was the thing that bothered me the most, the right lens, and it didn't really seem to matter. So I decided to try to plan that with a clearance map. So that's, that's the original VMAT 2-field plan, and you see there's no collision. It's close here, but it will clear. And the 3-field, since it's, again, 0 couch, it clears. It gets close here, but everything looks green. So now, a 3-field non-coplanar where I basically just added this couch at 90 and a G0 to 100. I reduced the hotspot a little bit, which made me happy, but also the lens dose dropped by 200 centigrade into a more acceptable range. So that was good and is deliverable for us, but I had a collision with that plan. So I didn't realize that until I re-exported it to MapRT, and my chosen couch kick arc situation collided with the table. So back to the drawing board, and I quickly just changed it to G90. And just comparing my non-coplanar brain constraints versus the regular coplanar 3-field, you can see everything looks better. I'm still hitting my lens goal, and my hotspot would be probably acceptable. So that was encouraging. And here's the clearance map once it clears. It gives me a warning, like Helen said, about transitioning between 2 and 3, but it all looks good. So that gave us confidence, and then I switched to the breast, which is more of our focal point in my clinic. And again, David provided a really interesting patient setup with, we're treating the left breast, and her left arm is up and in the way. So it's going to be an interesting clearance issue, which ended up being not really a big challenge. So again, more of our traditional 3D conformal plan, 2 tangential fields. Coverage was good, but there were some slight deviations from what our objectives, what we wanted to be, mainly in the lung. The heart looks good, and the PTV coverage. So that clearance map looks like this. Ignore these. These are our imaging fields, and they're flagged for some reason, but that's not a big deal. Those are the 2 treatment fields, and they look good. So now, non-coplanar 2 fields plan. So basically, at each field, I kicked the couch by about 30 degrees, and then I kept this one at 0 just to see how that looked with just one couch kick, and then comparing that one to our baseline 3D breast plan. So everything looked better, coverage seemed better, but I still had that pesky lung dose that I wanted to try and see if I can reduce it. So, and again, I have a problem with field 1. So there's a collision here. So I'm stuck with the higher lung dose that I want and a collision. So again, back to the drawing board, where I'm going to try 2 couch kicks that are just 10 degrees. I changed the field orientation a little bit, and it looked better. So coverage is good. I reduced the lung dose more. I could have done more, but I wanted really to keep it similar between the two, the time spent between the two, and the amount of iterations that I'm doing, and my field clears. So another successful trial for us, and we moved to the next case that we wanted to try was the lung, and in this case we have that immobilization kind of unit thing that we don't use in our clinic, but it would have been interesting to see how it looked with the planning. So again, our traditional approach to lung planning is a couple of EMAT arcs, and it looks good except for the hot spot. And this is how the clearance looks, pretty wide open, straightforward. I decided to try just one couch kick and see how that looks. Was able to lower the hot spot. The coverage still looked good. Just clearance map. It passes. It gets close here, but nothing to worry about. As was shown in previous talks, it's pretty accurate to 1 millimeter. So I mean 1 degree. So it's nothing to worry about here. And so we were happy with this one, and we would have treated it with that couch kick easily and without any worry. So looking at just those 3 plans, because we have a lot more plans to analyze and we through, but it just takes a lot of time to create all these plans. We don't have a resident like David that can do all the work. I do it all myself. So we were looking forward to do more and more. And as we get our system installed, we will probably have one of our own surfaces and be able to do a more one-to-one comparison. But we came to the conclusion that non-coplanar treatments can have clinically significant impacts for all treatment plans. So MapRT gives you the option to actually test it on any kind of treatment that you might think of, even if it's extremity or breast or lung or abdomen or pelvis. It just gives you that clearance map, and you can always kick the couch a little bit and see if it actually makes a difference. And it gives you another layer or another tool in your toolbox when you're trying to optimize a plan. You can use it to improve your target coverage and hotspots. You can improve or lower your ORI dose, or even reduce the total amount of MUs, which reduces the amount of time a patient needs to be on the table, which can result in a better outcome at least for the patient. So MapRT will provide a clearance map that helps prevent replans and eliminates dry runs. And it could actually improve the quality of the treatment plan as it's delivered. Really big thanks to David for giving me all those plans and giving us a little preview of MapRT before we get ours installed. And Glenn from Visionary that helped me figure out all the software stuff. So, thank you.